Sexton, KCOM, Associate Dean for Curriculum. I'm also the project director for the primary care training and enhancement grant that we have through HRSA. And so as part of that, we're able to bring in excellent speakers. Many of you have been part of Primary Care Week all week in conjunction with help from other clubs and organizations supporting this, and as well as AHEC here in town. We've been super lucky to have great speakers, and this is the culmination of that. Please do fill out when we're finished today or as we go the evaluation that's at your place. You need to use the pencil. It's like the whole retro fill in the bubble kind of thing, just to make you feel like you're really old. So today we have Ned Presnall from St. Louis, Missouri. Mr. Presnall is the Executive Director of Clayton Behavioral Health and an adjunct professor and senior data analyst at WashU. He presents widely on topics of addiction, mental health, and the opioid epidemic, which it's no surprise to see such a great crowd, because you all know how big a deal this is. Mr. Presnall also consults with the Missouri Department of Mental Health as part of the state targeted response to the opioid crisis. And so today he'll tell us about his work, and we'll learn a lot. So please welcome Ned Presnall.
Thanks very much. I'm going to go kind of quick today because I got a lot to cover in this short time. The subtitle of my presentation is this: we can't reverse the overdose epidemic without primary care. And I'll explain why as I go on. I guess most of you in this room are becoming physicians. I just want to put a pitch before I start, just so I don't forget. I'd encourage every person in the room who's studying to be a physician to get waivered to prescribe buprenorphine. You may have no intention to do addiction medicine. You will meet people in your practice who you can treat and help with buprenorphine treatment in any practice setting. And in many cases, that treatment will be life-saving. What do you notice about this chart? This is a chart of the AIDS epidemic. How would you describe what the story that this chart tells?
Less people are dying from AIDS, getting better treatment. Maybe.
All right, so when did that start? When did that change? Oh, yeah, there's a bar there. Yeah, that's right. 1997. 1997, you see the introduction of highly active antiretroviral therapy. And at that point, you see the deaths associated with HIV and AIDS plummet immediately. And you see an increase, both these blue lines are an increase in people living and managing HIV and AIDS effectively. That means, yeah, they have a chronic condition that requires chronic treatment, and yet they're not dying at the rate that they were dying prior to the introduction of effective treatment. This is the opioid epidemic, perhaps. So looking at this chart, we don't see any arresting of the deaths associated with opioids. In fact, we see this fentanyl really sub-epidemic within the opioid crisis. But still, prescription opioid deaths continue to rise. Heroin deaths rising rapidly over the last 5 years. So what do you gather from that? If we compare that to the AIDS epidemic, what's the takeaway? We don't have effective treatment. That's what you would imagine. Because if we did have effective treatment, it would be diffused throughout the healthcare system. People would receive it, and you'd see the deaths go down and the number of people managing opioid use disorder, which is a chronic condition, going up. So, are you gonna, oh, you're gonna, okay. All right. So this was a paper put out by the Global Commission on Drug Policy just last October, and it goes through all the evidence-based treatments, analyzes the opioid overdose rates and trends, and draws some conclusions. And one of the conclusions it draws is that it's not that we don't have effective treatments for opioid use disorder. In fact, we have treatments that reduce mortality risk tremendously, which I'll explain. but only 8 to 10% of treatment programs offer opioid substitution therapy. That's treatment with methadone or buprenorphine. Those, by the way, are the only two treatments with demonstrated effectiveness for reducing opioid-related mortality. For the last 7 or 8 years, I've taught a course on addiction to social workers at Washington University. And I start every class by saying, okay, if you can find me a well-controlled clinical trial that shows that psychosocial treatment, which is what they'll be delivering, which is what I as a social worker deliver, that psychosocial treatment reduces risk for mortality associated with opioid use disorder, you don't have to do any other work over the class. There is none. And yet there's decades of research showing that both methadone and buprenorphine reduce opioid-related overdose death. So oftentimes opioid use disorder and other substance use disorders are compared to other chronic conditions. And it's an important comparison because that's what it maps best onto, both in how it develops and how it's treated. So if you compare it to type 2 diabetes, it's heritable. There's some genetic vulnerability that's activated by environmental exposure. It's progressive. And usually to manage it effectively, you need both medication and lifestyle change. And typically over the course of a person's illness, they have flare-ups and they have to change their treatment and they age and treatment changes over time. Sustained uncomplicated remission is the exception, not the rule. And that's true with opioid use disorder as well. People have periods of sobriety, they eliminate certain substances of misuse. But only in the field of addiction do we idealize full remission compared to what we do in the rest of medicine. In the rest of medicine, if you had a patient whose symptoms decreased and their risk for mortality and morbidity decreased by 50 to 60 to 70% because of changes they were making, and they were getting better, but they weren't perfect, you would think of that as a success. That's what most of your patients are going to experience when you treat them, depending on what specialty you're in, if you're treating chronic illnesses. But in addiction treatment, traditionally, we've said, okay, if you're not fully abstinent, if you don't make huge moral changes in your life, if you don't start becoming more honest and doing all these things that are sort of like these moral paragons, then you're not recovering well from addiction. That's really not the way we look at illnesses. It's the way we look at behavioral problems or character. If we really want to look at addiction as an illness, we have to start visualizing the entire course of the illness and the treatment in that way. So there was this study that looked at the treatment of type 2 diabetes over 4 years. And it really wanted to see how much you could leverage lifestyle change in managing type 2 diabetes. And so people were randomized either to treatment as usual, which would be seeing a physician or a prescriber, and they would get some health coaching and be prescribed medication. Pretty much everyone in this study was on medication when they started to manage the condition. At the end of a year, okay, so the comparison group or the treatment group got really what looked very much like intensive outpatient treatment for addiction. You go to groups multiple times a week, you see a counselor, a dietitian, you get social support, you set really strong behavioral goals, you're held accountable for meeting those goals, diet, exercise. And the idea was, hey, maybe we should be, investing more in the behavioral aspect of type 2 diabetes and seeing if we can manage people's condition. Maybe some people at the end of a year or 2 years will be able to get off medication to manage the condition. Well, at the end of 1 year, in treatment as usual, which was seeing the prescriber, getting some health coaching, 3 out of 100 people were able to come off their medication. And in the treatment condition, 11 out of 100 people were able to come off their medication. So that's fairly effective, right? There's a decent effect size there. It does show that you can get something out of lifestyle change, and maybe we should be focusing a little bit more on lifestyle change and facilitating lifestyle change in treating type 2 diabetes. But if you took these 11 people and you put them in a room together and you said, so can people get off medications through lifestyle change when they're treating for type 2 diabetes? What would those 11 people say? Absolutely. What would you say as a scientific practitioner? No. In general, 89 out of 100 times, even with intensive lifestyle change efforts, people have to stay on medication in order to manage their illness. What if we generalized from this? What if we said, you know what? Those 11 people did it. It works if you work it. So now we need everybody else. We're just going to prescribe that to everybody. We're just going to start taking people off of medication and saying, listen, these 11 people could do it. You can do it too. And it's just sort of weakness, or, you know, you're not strong enough if you're not doing it. What would be the result with type 2 diabetes? We'd see a massive increase in the morbidity and mortality associated with diabetes. But that's exactly the state of affairs in the treatment of opioid use disorder. We have effective medications. We know from the science, which I'm about to review with you, that the only thing that works, the only thing that stabilizes people in general, there's always exceptions to every rule, but in general, the science shows the only thing that works are medications, and yet only 8 to 10% of treatment programs around the country offer people medications. Now, the big reason for that is that all the treatment is happening in what's called specialty substance use disorder treatment programs, by and large. And with the exception of federally regulated opioid treatment programs, those have traditionally been psychosocial only treatment programs. They've introduced medication a little bit for like detoxification, usually alcohol detoxification, maybe a little bit of medication to detox people with opioid addiction or benzodiazepine addiction. But by and large, use medication as sparingly as possible. And you try to use psychosocial behavioral change to manage an illness that we know doesn't respond to that. Well, where has primary care been in all of this?
Referring them to those people.
Exactly, referring them to those people. That's the best answer I've heard. Seeing someone for whom the core competency that's required to treat them effectively is right there in you, so long as you have the waiver, and referring it to agencies that don't have a core competency in medical disease management. That's how our system treats opioid use disorder, and that's why we haven't been able to arrest the increase in opioid-related deaths. So the science of recovery looks like this. This is from a Massachusetts Medicaid data set, so all the people in Massachusetts who are receiving Medicaid, looking over 3 years, everybody who received an opioid use disorder diagnosis and got any treatment. These are the folks that received buprenorphine or methadone. The green line is the people that received any psychosocial treatment only. Everybody received treatment. In the first month, the relapse rate, which means that you went to the emergency room with an opioid-related cause, were hospitalized with an opioid-related cause, or needed medical detoxification, was 9 times higher than in the buprenorphine and methadone groups. And that difference persisted, although it changed over time, over the course of 3 years. But this underestimates the effectiveness, the relative effectiveness, because if treatment is not effective, people just drop out. So at the end of a year, only 12% of the people who were receiving psychosocial treatment were still in treatment, compared to 33% in the buprenorphine and 52% in the methadone groups. We have, in 2017, we got a really large meta-analysis of all cohort studies. Cohorts, of course, are large groups of people in real-world conditions followed receiving certain types of treatment. And in the cohort studies put all together for methadone, every good cohort study we have, over 122,000 individuals followed over 1 to 13 years. When people were in treatment, that means when they were receiving medication, their risk for death was 70% lower than when they were out of treatment. So the question is, well, you know, when people always, like in any management of any chronic condition, people come in and out of treatment. They take their medications for a while, they feel better, they think maybe I don't need this anymore, the treatment's inconvenient, they discontinue it, then they come back again. When they're in treatment, their mortality risk was 70% lower in methadone treatment versus out of treatment. And looking over 1 to 5 years, because buprenorphine was introduced in 2003, more than 15,000 individuals, the risk for death decreased 50% when people were in treatment versus out of treatment. Now, sometimes when I present those sorts of findings, people say, okay, Ned, yeah, you're saying people don't get medical treatment, and the medical treatment obviously reduces mortality risk, but would getting people effective treatment really reverse the overdose epidemic? I mean, the overdose epidemic, it's the largest epidemic of mortality, acute mortality, in our lifetimes and in a few generations. Of course, I put aside obesity and smoking, which are kind of the plateaued, longer term. But in terms of acute mortality epidemics, single cause, We have more annual deaths now related to opioid overdoses than in the worst year of the AIDS epidemic, before there was effective treatment, the worst year of car accident deaths before there were seatbelts, and the worst year of gun violence deaths in the United States. It's the single biggest epidemic that we've experienced, single cause epidemic. So could we address this epidemic of this magnitude and decrease the overdose rate just with effective medication? And my argument is yes, because we've seen it happen elsewhere. Now, granted, France's opioid epidemic was not a fraction of what ours is, but when they saw their overdose death rate climbing, they introduced buprenorphine many years earlier than us in 1996. They had no waiver requirement. They had any doctor could prescribe it. They started prescribing it in primary care. And as people rapidly got onto treatment, the number of overdose related to opioids decreased. So you can see even in a geographical area, when there's full diffusion of effective treatment, it can reduce mortality risk considerably in that geographic region. Now, we have so many barriers to buprenorphine treatment in the United States, the biggest one being the need for a waiver. And I don't have a lot of time to talk about this. There's a political history to the fact that you need a waiver to get buprenorphine treatment, but just ask yourself this. Why, as I enter the medical profession, can I prescribe as many Schedule II narcotics as I want, Schedule II opioids that cause overdose death, and I have to get a special DEA number, go through a special 8-hour training to prescribe a Schedule III medication, which is what buprenorphine is, that has a ceiling effect for respiratory depression. In terms of someone killing themselves, it's safer than old antidepressants, and certainly safer to all the prescription opioids that you'll prescribe that can kill people if they take all of their medication at once, right, with respiratory depression. So why is that? Well, it's completely political. It has nothing to do with medical science at all. And in France, they realize that, so they're like, oh, Schedule III medication. They have different scheduling, but safe medication, anybody can prescribe it. We have to address this epidemic, and they had a really positive effect. In Baltimore, where the overdose death rate has traditionally been among the top cities in the country, when the medication came out, they had very rapid uptake, and they had a Baltimore buprenorphine initiative that let's get people medication as quickly as possible. And as they got people on medication, they saw their overdose death rate start decreasing for the first time in many years. Now, since then, it's gone up again. There's not enough access for all the people that have been hit by this epidemic. But we can see that we can, through full diffusion of effective treatment, make a difference in overdose death rates. And yet, our system's not built for it. So as the number of treatment episodes and specialty SUD treatment centers has gone up with the opioid epidemic, the number of episodes that involve medication have remained somewhat stable. Now, in the last 2 years that aren't shown here, in 2016 and 2017, especially in 2017, Missouri's made a big push to get people medications. We'll be able to see from the next round of data what kind of effect that has. It has not yet arrested the increase in overdoses. We had an increase in 2017, just like we did in 2016. But the hope is that through diffusion, we will start to see a decrease. The big misconception is that if you're in primary care or you have your own private practice, you're doing some sort of private specialty, and you encounter people with opioid use disorder, that you have to refer them out to a place that has more treatment because you don't have the competence you need, or you don't have the staff you need, or the type of treatment you need to treat opioid use disorder. This is a Cochrane review. You should all be familiar with that. It's where you do the meta-analysis to show really what is effective for all kinds of conditions. This is the most recent meta-analysis that asks this simple question. When people receive buprenorphine or methadone, how effective is it to also add on to it some kind of intensive psychosocial treatment, whether that be motivational interviewing or cognitive behavioral therapy or contingency management? Those are the main ones. And the answer is, in terms of retention and the prevention of illicit opioid use, it has no additive effect. No additive effect. Now, I'm a social worker. I run groups for people with addiction. I don't take away from this the idea that psychosocial treatment is not helpful, or indeed very important for people that are pursuing recovery. But the idea that we should be front-loading it in this intensive way does a number of things. One, it doesn't treat the problem as a chronic condition. you're going to be treating people with opioid use disorder over many years, not for 30 days, not for 30 or 60 days. You wouldn't do that with diabetes. You wouldn't say, okay, we're going to put you in diabetes boot camp, and then we're going to do nothing. Go to a group and talk to people that also have diabetes about how you have diabetes and how you need to manage it. It's just not a rational way. And not only that, but it creates this huge barrier. People with opioid use disorder are like everybody in this room. They have families, they have jobs, they have things they have to do. When someone says, okay, we're going to treat you, but you need to come into this major rehabilitation program and be here, 40 hours a week at first, and then we'll step you down to 20 hours a week. For most people, that's just simply not possible. Now, in certain cases, people do, like in every other condition, so in certain cases, people need to be hospitalized to be stabilized, and they need a certain amount of time. But in the vast majority of cases of people with opioid use disorder, they can stabilize in an ambulatory setting, and any barriers that are put up to them receiving medical treatment or staying in care, being retained in care, tend to get them to drop out of care rather than help them recover over time. So I think what this really shows is that we need to be titrating care effectively over time rather than giving it all at once. And this is shown in a study that looked at why people discontinue buprenorphine maintenance. Most people don't discontinue it because they want to. They discontinue it because there's certain requirements that they need to meet in order to get it. How many endocrinologists would say, all right, you come in, all right, now you have a patient who's obese, they have a poor diet, they have type 2 diabetes, and you prescribe some medication and you say, hey, you're going to be able to manage this condition a lot more effectively if you also make a few lifestyle changes, right? If you cut a couple things out of your diet, maybe start walking a couple times a week, just getting the blood flowing. And you know what? See this dietitian, because he or she can really help you a lot in terms of trying to make changes over time to your diet and kind of live a healthier life. So your patient comes back at the end of a month and says, Doc, I took my medication every day as prescribed. Now, first of all, right there, that when they say that, you're doing backflips, right? That's a compliant patient. It's someone that showed up again and did exactly what you said, but didn't see that I skipped the point with the dietitian. I kept eating what I was eating, that I've been eating for the last 40 years. And like the last 20 or 30 years, I didn't get a lot of exercise. I didn't start walking. I'm busy, and it's hard to make that kind of behavioral change. Which endocrinologist would say, well, all right, no medication this month. Let's see how that feels. Happens all the time in addiction treatment, where people can't get to see the doctor because there are psychosocial treatment requirements that if they miss, they're out of the program. And if they're out of the program, then they can't see the doctor. This happened, a physician friend of mine who works in the opioid field said that he worked at a treatment center once, a specialty treatment center, and they had a young man with high functioning autism. And he'd overdosed on heroin 3 times in the local hospital. And finally, they got him stable on buprenorphine. He started coming to the treatment program. He was a compliant patient. He was going to all the groups. After more than a year, very stable still. His family said they hadn't been this healthy in a decade. He started smoking marijuana again. Now, it was a pretty strictly abstinence-based program, so they said, you got to stop smoking marijuana or you can't be in our program, and we're going to give you some chances, but you've got to eliminate your use, and then you get a urine toxicology that's negative. So he said no. He said, it's not harming my life. I'm going to keep smoking marijuana. So the physician went to the clinical director and said, listen, I get that this guy, according to our protocol, gets ejected from the program, terminated from the program if he's not going to, be abstinent. But we cannot take him off his medication. His medication saved his life, and it's keeping him stable. And the clinical director said, nope, those are the rules of the program. We've kicked other people out because they refused to adhere to abstinence, so he's out. So he discontinued treatment. Within a month, he was dead. And that's a shocking story, but it's normative. Happens all over the country every day, that people are taken off their medication when it's not indicated. They're refused medication when it is indicated. They're told to go to places where they're not going to get medical treatment. They're sent home. They go to treatment on medication. They get sent home off of medication. And all of these decisions, which are not based in clinical science or medical science, result in higher mortality. It's also thought, erroneously at times, that if people are on medication, it's somehow a crutch. That if they get the agonist or partial agonist medication, methadone or buprenorphine, that somehow they're just going to work less hard in recovery. They're not going to make the changes that are associated with recovery. And so that's one of the reasons not to provide the medication. We don't have a ton of studies on this particular topic, but the ones that we do show exactly the opposite. And what we understand of the medications, it makes sense. When people have out of control cravings, how well are they able to engage in goal-directed activity? When the limbic system is activated through anger or craving or emotion, how easy is it to focus on the tasks at hand, to set goals, to think about the future? It's very difficult. The main thing that these medications do is quiet that limbic system craving so that people can concentrate on their lives. So in this one study we have, where it was an open label study, 173 people followed over 18 months, they could stop medication or stay on medication. At 18 months, the 76% who decided to stay on medication, which is common, people do not want to come off the medication when they're on it, the people that stayed on it were more likely to report attending an AA home group, having a sponsor, attending 3+ 12-step meetings per week, and just living and not engaging in all of the things that we associate with addiction. So the medications actually enhance a person's ability to engage in all the recovery supports that help with their lives. They're not exclusive by any stretch of the imagination. Now, Missouri, as it designed a new approach funded by these recent grants, the State Targeted Response to the Opioid Crisis and the upcoming SOR grant, said we really need a different approach. The leaders in Missouri said, we can't take all this money and fund it into the type of treatment that hasn't been working for decades. So what are we going to do? And they looked to the housing first model. The housing first, there used to be a housing readiness model of care when we were dealing with homelessness, where people had to meet one X criteria, Y criteria, Z criteria in order to qualify for housing. And then once they were in housing, they had to meet certain objectives in order to retain housing. Now think for a second how important housing security is for a sense of stability in life. If anybody in this room didn't know where they were going to sleep tonight, I guarantee they wouldn't be taking in very much information about buprenorphine and methadone, right? It's a survival need. When we're in survival situations where we go into a mode that is not focused on the long term, that's not setting goals and meeting objectives. So someone came along and said, look, people don't seem to be getting very stable through these housing readiness programs. How about we focus on housing security? How about we treat homelessness with housing? First, we'll just get people with homelessness secure housing and then voluntarily recruit them to engage in other types of rehabilitation. Well, surprise, surprise, it works really well. The medication first model is similar. It says, let's get people who have a biological illness, a physical illness, with their opioid dependence. We know that it's chronic from studying it epidemiologically. Let's get them stable medical care. They can't lose it. They don't have to jump through a bunch of hoops to get it. Let's get it right away, stabilize them medically, and engage them in voluntary support services as needed. That sounds normal to you probably because you're in the medical field and that's the way most medical conditions are treated. But for opioid use disorder, this was a major change for providers. It is, however, not something we just cooked up here in Missouri, although we are the show me state and we can take pride in our model. But the World Health Organization said it in 2011 when they put out their guidelines. They said treatment services, by which they mean any kind of treatment agency, should not deny effective medical treatment, even if they can't provide any psychosocial services. If you can provide medical treatment, provide it. There are other agencies that provide psychosocial supports and people can access them there. Great to offer them if you can, but it's not entirely necessary. And while patients should be offered psychosocial support, either through your agency or through collaborating agencies, they should never be denied medical treatment if they refuse such support. So if a patient refuses to see the counselor, they shouldn't lose their ability to see the doctor and receive life-saving medication. The Missouri Department of Health institutionalized this in new guidance for their providers, especially the providers that receive the new grant funding are really required to adhere to this. And it basically just is the same requirements I talked about. People get medical treatment as quickly as possible. They get individualized psychosocial treatment that's voluntary. Medical treatment is not terminated arbitrarily or unless it's really clear that it's worsening the patient's condition. What had been the norm, like I said, is that medications would often be used for detoxification. Even where they were used, it would be a 2-week taper, a 3-week taper, a 4-week taper. But the idea was always, we got to get people off of medication. That's the end goal we're going for. We have no medical science to support that protocol. The World Health Organization specifically warns against using a detoxification protocol because we simply have no science to support it. There's not one study that says, okay, let's compare people on maintenance treatment and compare people who are detoxified or like tapered off of treatment and look at the outcomes where the people that were tapered do better under any protocol, even at 6 months, even at 9 months. Every taper protocol in the scientific literature is associated with a worsening condition in the group of people treated with it. Now, this is just this is a very small study, but it's the most pure study of when people just receive medication. It's a waitlist study. So in a lot of, before STR in Missouri, if you called to get treatment for an opioid use disorder or another substance use disorder, how long would you have to wait?
8 months.
Very often months. It could take 8 months to get into treatment. Oftentimes they would say, well, there's a 2-month waiting list, but just keep calling. Call every day. Well, people with a substance use disorder do not often have the persistence to or the mental capacity when they're in the cycle of addiction to call every day reliably. But nevertheless, that was often the protocol. So in one place they said, well, gosh, we can't get people into comprehensive care, which is the goal, but let's just give them medication. We'll have a waitlist condition and we'll put people on medication. Well, when you follow those people who were just given buprenorphine over the first 84 days, this was their days past month illicit opioid use in the waitlist condition. And this was the past month illicit opioid use in the people that were received no medication, right? So the people that got medication and didn't get medication. The irony of this waitlist study is that this is a better outcome than what you would get if you had gotten into the comprehensive treatment program, which oftentimes would have taken you off your medication, right? So I mean, the medication is highly effective. That does not mean psychosocial treatment should not be offered as an adjunct to treatment, but it needs to be our first line of treatment. That's it. First line of care. Do you often treat people with kind of the frontline medication and also add adjunct treatments? Absolutely. But medication needs to be our frontline treatment. Psychosocial needs to be adjunct. Now, what I said about primary care at the beginning, that, and you said this great answer that what would you do in primary care if someone with opioid use disorder came? You'd refer them to a specialty substance use treatment program. That's been the way it has been in the entire healthcare system. So if someone shows up at the emergency department, if they're lucky nowadays, pretty much everywhere, and they have an overdose, the Narcan or naloxone will be used to reverse the overdose. And then they'll be given a list of places to go get treatment and be sent on their way. No treatment will be initiated in the emergency room. If they happen to have IV drug-related infection, and they have endocarditis or joint infection, and they require 4 to 6 weeks of IV antibiotics, they'll be hospitalized. And they'll be given antibiotics to treat the complication of IV opioid use disorder. And the opioid use disorder will not be treated. They will not be treated for buprenorphine or methadone by the infectious disease doctors. It's rare, very, very rare that in the hospital there would be an addiction consult that would come and treat the addiction in the infectious disease department. They just do not treat it. So people in Barnes-Jewish in St. Louis, 20 to 30 people have this condition at any given time, IV drug-related infections. And until recently, now they're just exploring the idea of treating those conditions while hospitalized, but generally people receive no treatment. In the criminal justice system, which is one of the largest treatment providers for mental health and has the largest population of people with mental health and addiction in the country, it's very, very rare that people will receive medical treatment for their opioid use disorder, even though they'll receive medical care for some things. If people go into jail on methadone or buprenorphine, 99 times out of 100, they'll be taken off their medication and have to go through physical withdrawal while they're in jail. So there's no integration of medical treatment in the healthcare system, and also in psychiatric hospitals are not usually equipped to continue people on buprenorphine treatment. So if we do start integrating treatment, what it looks like is People come to the emergency department. This is a large study from Massachusetts. The comparison group are the people that had a non-fatal overdose and did not receive any medication in the next 12 months. That's the comparison group. That's why it's 1. If they received any buprenorphine or methadone in the next 12 months, their risk for death decreased 70%. But only 30% of people in Massachusetts, who has one of the better programs, that's why we have all these studies from here, because they actually link their data and they're able to tell us what's happening in the full system. Even in Massachusetts, only 30% of people, only 30% after an overdose, a non-fatal overdose, received medication. In this group right here, what do you think the 12-month mortality rate was? What percentage of people who have a non-fatal overdose die in the next year? 80%? I know. People usually actually guess high. I should never use that as a rhetorical. 1 out of 10. But a 10% 12-month mortality rate is astronomical for any condition. And to know that just by treating it, just by getting people medication, we're going to reduce that risk by 70%, and yet it's still, the diffusion of that treatment is very low. And in some states, much lower than in Massachusetts. If you look at the criminal justice setting, so these are all things that are happening really recently, right? So in Rhode Island, they said, okay, one of the highest risk groups are people who have been incarcerated. Because when people are incarcerated, and sometimes they'll continue using while incarcerated, a lot of times in jails, they have no access to it, and sometimes in prison, they have no access to opioids, or they choose not to use it because of the environment. So a lot of people stop using in prison. Now, some people think, well, that's great. Well, they get a lot of time where they're not using and they go back to their natural environment. What happens when you stop using opioids?
Feel horrible.
You feel horrible, you get through it, and then what happens to your tolerance? Goes way down. When someone leaves an incarcerated setting of sensory deprivation, basically, of deprivation of all kinds, what happens to their cravings? Goes through the roof. So we have 2 things that happen medically during that time. Tolerance goes way down, and there's a conditioned response when people re-enter their environment where their cravings go way up. So people are 12 times more likely to die in the first week out of incarceration than in the general population. And almost all of that is from drug overdose. So in Rhode Island, where they're trying to get a handle on their overdose crisis, they said, okay, we're going to treat everybody with an opioid use disorder who's incarcerated in jail and prison. And so this is the number of people that were treated with buprenorphine, methadone, and naltrexone in the first 6 months of 2016. And these are the numbers for the first 6 months of 2017, right? So they basically gave everybody treatment. And then once they got treatment, they were connected to providers when they were released from incarceration. In just that 1 year, they had a 60% reduction in the proportion of overdoses among recently incarcerated individuals. Now, does anybody know a number needed to treat for any condition? Can you say, like, number needed to treat with aspirin after a heart attack in order to, just give me some comparison? A negative event. There's a website where you can call number needed to treat. You can go on, you can look at all the numbers of needed to treat for different conditions. I always try to think of an example. I always forget to have one. I think it's something like 100 people need to get medication following a heart attack to prevent another heart attack in the next year or something. The number needed to treat to save a life among incarcerated individuals in this Rhode Island study was 11. If we just treat 11 people with medication while they're incarcerated, we're going to save 1 life. And yet still, this is experimental. Like, this is rare for people to receive medical treatment. Now, in the prisons in Iran, everybody with an opioid use disorder gets methadone. So that's the way that, I think that's a funny comparison. It's easier to get methadone treatment in a prison in Iran than it is in Kirksville, Missouri. So overall, with this effort and with additional efforts, 12.3% reduction in overdose deaths statewide. Rhode Island was one of the rare cases where they were able to identify the people with the highest risk for overdose, one of which was the incarcerated population, and they were able to actually bring their overdose deaths down. In in St. Louis County this coming year, the St. Louis County Jail, we're going to start having buprenorphine treatment as well. So this is a study that I and my colleagues at WashU just recently submitted. It hasn't been published yet. It's under review at a journal. And what I want to show you is in the state of Missouri, how people are receiving buprenorphine treatment. Now the settings are, the SUD setting is the specialty SUD treatment provider. The outpatient, OPH is outpatient hospital. OBOT is office-based. That's any kind of primary care or just office-based setting. And FOB is something we'll talk about in a second. That's a sort of special group. What this shows is that the risk for terminating treatment, when you compare it to specialty treatment, buprenorphine, is lower in these mainstream healthcare settings. People stay in treatment longer when they're receiving it in OBOT, office-based opioid therapy, or in an outpatient hospital. And do you think you could move this for me? And when you compare these settings, outpatient hospital and OBOT, to the specialty substance treatments, there is a 30 to 40% reduction in the risk for emergency department visits and 40 to 50% reduction in hospitalizations, all-cause hospitalizations in those folks. And I show you this to really drive home the point. Here in Missouri, if you're treating people with opioid use disorder in an office-based setting, which many of you will be working in, that group, that setting has better effect in Missouri on retention and risk for medical instability than in the specialty settings that you typically would have referred your patient to. Now this group is a really important group. It's the only group that has worse retention than the specialty SUD provider. However, when people do receive it, it's just as effective for reducing risk for ER visits and hospitalizations. This comparison here is when people receive psychosocial only treatment. Naturally, they're more medically unstable. And if you compare, obviously, if you compare these effect sizes that are flipped, they're much, much less stable than folks who are getting office-based treatment. The FOB group are the people in the Medicaid claims. I remember when I said I was a senior data analyst, that's what I do half my time as I look at data. I was like, what are these people? What am I doing wrong in my coding? I can't find their provider visit. They're getting medication they're getting their buprenorphine through Medicaid benefit, but there's no associated physician visit. What do you think's happening there? They're just paying out of pocket. How easy is it to find a buprenorphine provider that takes Medicaid? Very difficult. It's very difficult to find a buprenorphine provider anyway. So if you do find one, they may treat they may take insurance for everything else, and they make you pay cash for buprenorphine treatment because it's a captive market. People can make a lot of money prescribing buprenorphine because it's a supply and demand thing. So this FOB group says, I need buprenorphine. Maybe I can't go to a specialty SUD program. Maybe I can't get in, or maybe the requirements of the program are too great and it's too much of a barrier for me. And so I get in to see the doctor, but if I have to pay for every doctor visit out of pocket, naturally I'm gonna have a lower retention. Though if I'm receiving the medication, it's still very effective for reducing the risk for medical instability. All right, now you're gonna have to hook me up again. Thanks. So there are several studies. I encourage you, if you have an interest in this, to look at them on your own. Buprenorphine maintenance treatment in primary care improves people's adherence to the nationally recommended preventative primary care screenings. So when people are receiving opioid therapy, buprenorphine therapy in primary care, they're attending to other aspects of health as well. The models, one of the reasons I love the primary care model so much and the physicians who treat it is people come in, they get buprenorphine treatment, they get stabilized, then they get their hepatitis treated, they get their other chronic conditions treated, they get this full care that they don't typically get in the SUD treatment providers. In the SUD, I was talking to one primary care physician who does buprenorphine treatment, and she said, I'm going to moonlight at this specialty SUD place because they don't have enough providers. And when I'm there, I'm like, well, I want to treat their other conditions too. And they're like, yeah, we can't bill for that. So you just got to treat the opioid use disorder. So people don't get full health care when they go to a specialty provider, but you can provide that in primary care. There are great models for how to integrate it in primary care. This is a guidance that was put out by AHRQ. The model that I think is most detailed and seems really to be very effective, it came out of Boston. It's called the nurse care manager model. And really the nurse care manager model just makes it so you don't have to spend quite as much provider time with patients, especially on the front end. Patients with opioid use disorder are not difficult patients by and large. There's a little bit more that has to happen up front if you're going to do in-office induction. There's some debate in the field whether that's really necessary. A lot of places just do at-home induction, but it takes a little bit of management up front, and the nurses can do a lot of that so that you don't have to spend all your time with the patient. But once a person's stable, the change in condition is dramatic. The gratitude patients have, and most of these folks are very young. So they're not complicated medically generally. Most of the patients with opioid use disorder are in their 30s. And so once you stabilize them, they don't tend to be really complex patients. All right, we have 5 minutes for questions. Yes?
So what is the insurance coverage like for Suboxone? Is it just Medicaid?
No.
Or what are other insurance?
Yeah, most insurances cover buprenorphine products. Yeah, so Suboxone and yeah, that doesn't tend to be a big barrier. You might need to get prior authorization, but other than that. And in Missouri, right now, especially with all this grant money, Medicaid covers it, and you can find places that have reimbursement for the uninsured. So it's one condition that's pretty well covered for the uninsured. You just have to go to the right place. Yeah. That's right. Yes.
What would you recommend?
Well, the Missouri Primary Care Association is pretty active in trying to make changes. The HRSA has given a lot of money just this year to primary care settings. I guess, I would learn about where the money comes from in the federal government, where it goes currently, and lobby for more money to go to primary care. I can tell you more if you want. If you want to talk more, I can explain it to you in more detail. But that's the big issue, is that still the pathways for funding still largely go to the SUD providers, but that's changing. And the state of Missouri has done a good job. It has allowed any SUD provider now, and this is a really new thing and very unusual for any state, it can link up with a federally qualified health center, and they can kind of share patients, and patients can come in uninsured through the federally qualified health center and get state-funded treatment. So that requires a lot of collaboration. This is one of my goals over the next years. We've gotten one partnership to do it, and now that FQHC is the largest buprenorphine provider in the whole region where it is. I mean, it just catches on like wildfire once people have access to what we call low-threshold medication first treatment. So there's a lot of ways to get involved on the local level through the partnership with different agencies. On the state level, it's about really representing your profession as, the medical profession as a whole, abandoned addiction. Now there are treatments for opioid use disorder in particular, and it's really about just bridging the divide that have existed because of that. Mm-hmm. Yes?
Maybe I missed it at the beginning, but do you classify addiction as a disease?
Yes. Mm-hmm.
What role can dentists play in this, if any?
What role can dentists play?
Like with opioid, the
Buprenorphine?
Is there anything dentists can do? Because since we see patients typically more than physicians twice a year.
This is my main topic, is thinking about this question. I'm sure there are even better answers, but I would say 3 things.
Okay.
One is look at the guidance on the prescription of Vicodin and Percocet and the medications that are used to manage pain, and give what is the minimal amount that's effective for patients. Because one of the things we've learned is that longer scripts, even if it doesn't become a problem for the person that you gave it to, now get put into the market where other people are using it. The second thing is maybe learn to identify people who might be drug seeking. And rather than just telling them you don't want to treat them or turning them away, have a buprenorphine provider you can refer them to. and do that in a warm, gentle way. Even they may say, oh, give you a problem for it, but you say, from what you say, you can just say, if you have a problem with opioids, I recommend that you go to this provider. They'll take good care of you. And the third thing is with those patients, and this is true, I don't mention it enough, the standard of care is co-prescription of naloxone with anyone that is even a pain patient that is on a high dose of prescription opioids, or anybody that you suspect has an opioid use disorder. Naloxone is now a nasal spray. The Surgeon General said that everybody in the public should carry it in their purse and in their pocket. So it's just very easy to administer. And if you co-prescribe, it also gives you an opportunity to educate about risk and to make that available to people. Yeah. Any other questions? Yeah.
What kind of approach would you suggest we can take to prevent someone developing an addiction? You already talked about being aware of the drug seeking and that sort of thing, but there's this issue of we don't want to have people experience pain too much, right? But you don't want to cause an addiction to occur. So what is a good approach? And this is probably out, I don't know, it might be out of the scope of what you're talking about.
So in terms of prevention, it's being cautious about the amount you prescribe, and it's also taking a good history and knowing what type of risk people have for the development of addiction. If both of their parents are alcoholic, they're more genetically susceptible to developing an opioid addiction. You might not think that in your mind, like, well, people are alcoholics, but there's a shared genetic susceptibility for addiction across substances, and certainly across alcohol and opioids. So you might be even a little bit more conservative if someone has any risk factors for the development of addiction. We're the only state in the country that doesn't have a really active prescription drug monitoring program. I personally am not heartbroken by that because the science doesn't show that's helped very many places. What it does do is help people feel like they're not going to cause more of a problem, but there's not good pathways from that physician office where they're denied medication to treatment. And so really what it does is it drives people to the black market. And as there's been a restriction and a reduction of prescription opioids, which is good if someone if they're opioid naive, it's great to be conservative. If someone's already developed a problem and you become conservative in your prescriptions or start tapering people down, they're more likely to go to the heroin market. And when they go there, it's so lethal now with fentanyl and mixed in with almost all heroin on the market that just increases the person's risk for death. And so with both of those populations, it takes very different approaches. With the person that's opioid dependent, you want to keep them engaged. You want to prescribe as conscientiously as you can, but you definitely if you want to reduce mortality risk, the first thing is not to try to tape them off as quickly. It might feel like the right thing to do, but that puts them at risk. If someone is naive, being conservative about prescriptions while managing their pain. That's the dance you have to do. There was a change that happened where we became really conscientious about pain. It became, the fifth or sixth vital sign. It became assessed everywhere in the hospital. This all happened in 2000 when Congress passed this resolution saying this is going to be the decade of pain management and research. And everybody followed suit, and there's this big boom for the pain management, pharmaceutical companies and such. And physicians and prescribers were told, if you're treating legitimate pain, there's no risk for the development of addiction or very low risk. The last Surgeon General wrote a letter to every physician in the country and said, whoops, we got that wrong, which was mostly education by the pharmaceutical company, was passed on to doctors. It was wrong, scientifically wrong. It's like saying that you can't get addicted to alcohol if you only drink at a Cardinals game. There's just no real relationship. If a person has a genetic vulnerability to the development of opioid dependence and they're treating pain, they're still vulnerable. So we have to be conservative on the front end, but still try to manage pain, because when that all happened, in some sense, it was a conscientious response because pain was the most undertreated reported condition. It caused a lot of distress for people. And so we got to find the right balance there. But in terms of chronic pain management, I have a physician friend who's he's a board certified in ER medicine, pain medicine and addiction medicine. And he says that the only thing we know that really helps with the management of chronic pain are mindfulness and yoga. Opioids are not good for the management of chronic pain. They're good for the management of acute pain. So we have to really find that balance. All right, I think you guys have a quiz to go to, and I don't want to keep you late, but thanks very much.